to today's program. I am Kathy Brett with Becker's Healthcare. This informative webinar will cover coding and reimbursement tips for new and established orthopedic and spine technologies, unlisted codes, T-codes, and other obstacles to help recover lost revenue and optimize reimbursement for spine and joint replacement procedures. We will have a question and answer session following completion of the presentation, and you can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenter will attempt to answer as many questions as she can during the time we have, and any questions not addressed will be followed up with after the webinar individually. Also, during the webinar, you will have the opportunity to participate in several polls relating to the webinar topic. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. It is now my pleasure to introduce today's presenter. Carolyn Newman is Senior Manager, Coding and Coverage Access for the Reimbursement Management Center, or RMC, a coding and reimbursement hotline service offered by Specialty Healthcare Advisors, a subsidiary of Musculoskeletal Clinical Regulatory Advisors, also known as MCRA. Carolyn and her team of professional certified coders specialize in orthopedic, spine, and sport reimbursement pathway and coding support services, providing coding, coverage access, pre-approval, and claim denial management services that are in compliance with current established guidelines as established by the AMA and CMS, and managing the reimbursement hotlines on behalf of some of the most respected medical device manufacturers in the world. Ms. Newman and her team routinely respond to coding, reimbursement, and coverage access inquiries from surgical practices, hospital billing departments, and ASCs nationwide for both well-established and new technologies entering the market. It is now my pleasure to turn the floor over to Ms. Newman to begin today's presentation.
Thank you, Kathy. Good morning or good afternoon to all of you, depending on which side of the country you're on. Thank you for joining us and sharing your time with us today. We all know that there are many challenges in reimbursement, large and small. Here are presented 5 of the biggest that affect both orthopedic and spine surgeon practices and the facilities that they use. Next slide, please. We begin with the first identified reimbursement barrier, and that is the language of coding. As all of you know, coding is the language that we use to take anything and everything clinical and report it to our payers, third-party payers or Medicare for our reimbursement. One thing to note on this slide, up in the left-hand corner, there's a little lightning bolt. I've used this throughout the presentation just to emphasize areas of error, where error is possible and often happens and causes a reimbursement bump. As you'll see on this slide, coverage, coding, and reimbursement are the 3 big elements of healthcare economics that we look at daily from a practice and a facility point of view. We begin with obviously a clinical case, something going on clinically, and we have to put that into language of coding. That is represented by alphanumeric descriptors, different classes of procedures, diagnosis, locations, payment groupings. From there, we go to our payers, and they have coverage policies. And the 2 combine together, obviously, to affect the reimbursement status or the payment out of the available remuneration for the services that are clinically performed. Next slide, please. The next slide shows further the language of coding and barriers to reimbursement. As we know, coding provides the foundation of reimbursement. It refers to a language. I like to think of this as a language as opposed to numbers. But we have 5 digits currently, and soon to be 7 when ICD-10 arrives, to explain everything that's gone on clinically to a payer for their consideration of coverage. Accurate coding is, without a doubt, the most important part of this language. We'll talk about that in several different ways. But initially, I'd like to just go over the different code sets that are available. Sometimes we just say, oh, let's code it. What we really need to do is think about all of the code sets that factor into the ultimate reimbursement process. The physician, surgeon starts the process with the case, obviously with CPT coding. This is the procedure coding that the physician uses to report what he's doing. It's also used by the outpatient ambulatory surgery centers to either map to an APC for their reimbursement or in some cases actually report the procedure for a fee schedule reimbursement. You'll see that there's two different sets of codes. There's the CPT, which most everyone in the coding world is very familiar with, and then the APC, which is established by Medicare and denotes the procedures that are reported with CPT codes, is grouped in an APC for a particular reimbursement or a fee schedule. And then also important in this first section for physicians and also ambulatory surgery centers and outpatient centers are HCPCS codes. And HCPCS codes are used to denote supplies, devices, and some services for either line item reimbursement or just to accurately report what's going on. Next slide, please. Language of coding barriers again. As everyone has been talking about ICD-10, and many of us have gone to training for that, beginning to understand it. We have a hard date now of October 1st, 2014. If you'll notice, there's two pathways now. ICD-9 is one book. It has two sections, one diagnosis and one hospital procedure codes. ICD-10 is breaking that into two separate books per se with different coding systems. And if you look at the top of the slide, it's a little scary. Currently, ICD-9 diagnosis codes, there's 14,000. In ICD-10, there's 87,000. Hospital procedure codes likewise, 4,000 to 68,000. One of the things in the ortho spine arena is that 50% of the new ICD-10 diagnosis codes are in the musculoskeletal area and will be necessary for reporting procedures. There's also increases in spine and joint orthopedic coding in the procedure coding for hospitals, the ICD-10 PCS that's going to be starting. Language is becoming more complex. There's 7 digits now in these codes. 1 digit off and denial can happen. The bottom line is accurate coding communication is more and more important. There's more things to match up, and there's more reasons for denial. On the bottom of the slide, you can see ICD-9 codes, diagnosis codes, and hospital procedure codes go into the grouper to create the MSDRG, which is the ultimate inpatient facility reimbursement. That's very important that the diagnosis is correct and that you get the hospital procedure codes correct. In ICD-9, we've adjusted pretty well to that. Now we've got a whole new system. So the MSDRG process is kind of in question as well as where that's going. The language of coding is getting more complex. Next slide, please. This slide, I put this in a lot of presentations just to make people go crazy because it's kind of messy. Don't let it scare you. Coding system family tree. Important to know, though, when we're talking about coding, who has the authority? Who created the codes? And why are there codes in a certain section? And why do we have different codes for this? Take a quick look. It all starts with Department of Health and Human Services. Even in the private payer world, most of these coding systems are utilized. They've been created with the authority of Health and Human Services down to CMS or Medicare, who then works with the AMA for the CPT codes and creates or adopts the ICD-10 or ICD-9 codes that are going to represent procedures that are being done. These trickle down to MSDRGs on the facility side and also to the APC codes, HCPCS codes on the physician reporting side. Next slide, please. Why is the language of coding important? okay, for reimbursement. Number one reason for reimbursement denials are simple errors. And this can't be expressed enough. This is across all specialties and all services, but particularly in joint and spine when there are so many codes, so many diagnoses, so many things that interrelate. This simple error can create a disaster. These errors can happen just about anywhere. They can happen in your EHR. They were initially put in incorrectly. It can be a typo. It can be a transposition. The billing company may change the numbers. The example I put here is just simply a digit error for a total knee replacement. Everything's going along fine. It gets pre-authorized, 27447. Somehow it gets submitted as 27477. Not the same procedure, not even the same patient population, denied for any number of reasons, not matching up, not an age edit, something like that. Many of these kinds of errors go unnoticed because they happen in between departments. The person who clinically did it is not the same person submitting the code, who is not the same person working the denials or even posting the payment. So always, always watch out for the simple errors. Seems like it should be more sophisticated than that, but the reality is when you work in an AR department of a facility or even in the physician office, you find out that most of your errors, if you really look into them, are simple. Proactive claim audits can help this. You can see if someone's making a simple error over and over again, or if there's some part that's broken in the process. Next slide, please. Why is it the language of coding important specifically to joint and spine? Well, this is an example where clinical language is not the same as coding language. And I talk about it as a language because truly it is. If you've read the CPT book or the ICD-9 books, and the way things are stated, it very rarely translates exactly to what a surgeon is putting in an op note or an office note. This is an example that I've just pulled up, hits me in the face, clinical language of a vertebral segment in spine. When a physician is talking, he's generally talking about the whole ball of wax when he talks about that. In CPT, they break it into vertebral segment, which is the bony part, and interspace, which is the disc and the non-bony and the end plates. Coding terminology gets really convoluted when you get into any of the arthrodesis codes, segment, interspace. Segments are used in the laminectomy codes, interspace and levels are used in the discectomy codes. The codes typically don't really reflect the language of the code, what's going on. Audits find these errors. You can pick up on something that a dictation is just not getting through to the coders because of a simple language error. And documentation. In the end, it may not support your coding if you don't match up the words and the language. Next slide, please. Another area where language of coding comes into play is in modifiers. Some of us overuse modifiers, some of us never use modifiers in the coding world, but they need to be used appropriately, and when they are used appropriately, they can impact reimbursements quite a bit. Example here of, once again in spine, a bilateral procedure. Some of the codes are written as unilateral and need, if they're done bilaterally, to use a 50 modifier. If they're not, then there's no 50 modifier. But other codes are inherently what we call unilateral and bilateral. And it's very detailed. You have to read the code description, in depth. A lot of people, including myself, often don't have time for that. And if you're not familiar, it's very easy to miss the need for a bilateral modifier. Example below, 63030 is an inherently unilateral code for laminotomy or hemilaminectomy. Needs a 50 modifier if you do it on both sides. Laminectomy code 63047, similar codes and often interchanged by very minute differences. A lot of opinion on that out there. Is a bilateral or unilateral code, no 50 modifier. Why does it matter? Would you know if these were missing? And would you know at the bottom of the page if you look at even the reimbursement difference? This is Medicare benchmark. Certainly doesn't reflect everybody's reimbursements for these codes at any point in time. But if you forget the 50 modifier on a bilateral 63030, a laminotomy, hemilaminectomy, and just once a week, you're liable to lose that $500 in Medicare, and do the math over a year. I mean, it's a significant reimbursement hit. Next slide, please. Okay, second big reimbursement challenge, working together, the surgeons and the facilities. This is an area that's often overlooked. We're all very busy in our practices, so we're busy in our facilities, and we're worrying about our worries. But as we know, there are two distinct reimbursement pathways that are established for physician and also for facility. There are many things that exist in both sides that need to be either communicated or in some way the same. If you don't connect them up, there's problems working forward. The parallel systems and the coordination between authorizations, very important to make sure that your authorizations are communicated to the facility where the procedure is going to be performed. Your documentation, that's an issue that's coming forward. We'll talk about that a little later in the presentation. Needs to be shared, and the coding pathways need to be shared. As our digital age improves in its communication, I think that it's going to be a real reimbursement nightmare when things don't match up on both sides of the equation. Private payers are a little slow to catch up on that, but some of them are really connecting all the dots now. So communication, communication. We hear that in every workplace, but here it's really becoming important between the two sides of the reimbursement equation. Next slide, please. Here's an example that I've chosen just to illustrate all the different parts that may need to be communicated between the surgeon who's presenting the case and wherever he's performing the procedure, either in an outpatient facility or an inpatient facility. The diagnosis, very specific, may or may not affect payer policy, so it needs to be on both sides of the equation. The CPT procedure, although the reporting is done by CPT for the physician, an outpatient facility also needs to know exactly those codes that are going to be reported so they can put that into their reporting for reimbursement. And the documentation, once again. One of the little lightning bolts there is showing something that's kind of overlooked at times. Most people refer to fusion as fusion. CPT calls it arthrodesis, although that's well known. Most of you that are listening are probably aware of that. New coders coming into the scene, I've trained many, may not be aware of that. They may not be able to find a dictation or an op note that says fusion, that's arthrodesis. Important that that's communicated, the language again. Notice change down at the bottom there, changing in codes. In 2013 there was a change where two procedures, a posterior lateral fusion and posterior lumbar interbody fusion, were combined. There were two codes, now there's one code. Those kind of errors are being picked up now by payers, and the entire claim's denied when something like that happens. It's a change, you need to keep up to date. Sometimes those things are overlooked. There's small changes every year in CPT, and sometimes there's big ones that affect reimbursement. Next slide, please. This just shows the other side of that equation, how it's reported in an inpatient setting of care. Once again, diagnosis is important to share, and also the hospital procedure code is derived from not only the op note, but perhaps the CPT codes that are reported by the physician. So important to get that all communicated back and forth. Even when you're doing a pre-authorization, it's the time to share that. Notice in ICD-10 how things start to expand. They are not even all listed here. The page wasn't big enough. We had one ICD-9 procedure code for lumbar fusion posterior technique. We have multiple for ICD-10 PCS. This needs to go back and forth between both the surgeon and the facility so that they don't miss out on a small part. ICD-9, ICD-10 diagnosis codes, ICD-9, ICD-10 procedure codes together create the MSDRG. And if you're involved with comorbidities and complications, you need to have those diagnosis codes all presented to the facility on admission and also along through the process, through the stay in the hospital. Once again, working together. Next slide, please. The next slide is just an example of a different type of procedure that's could be often done in an outpatient setting of care. Same things need to be shared. In this case, if you look at the bottom, and also the second level of an arthroplasty, which is a total disc replacement. Once again, language and coding, beware that some coders may not know that arthroplasty is a total disc replacement. You have a T code here. And something, once again, we'll get to later in the presentation, but T codes are popping up more and more in spine. Any new technologies are that way in ortho situations, and a lot of outpatient settings of care are having to use T codes as well, and this presents a problem from them and for the physician side. On the next slide, we have the other side of this equation. Here is an example of all the things that need to possibly be communicated between the surgeon's office and the outpatient facility where the procedure is being performed. The CPT code, again, important to map to the correct APC. Notice, too, that most APCs are subject to multiple procedure reductions, which means your first APC is paid full. And these are Medicare rules, benchmark rules. Private payers have all kinds of different established rules on this. But first APC paid at 100% of its value, second APC paid at 50%, and so on. There has actually been, for 2014 OPPS proposed rules, the thought that this might change and that second-level procedures, many of them may not be paid at all. So it's something to keep your eye on. The new policies, changes to rules, they often creep up on us, and all of a sudden our reimbursements are not what we expect, and we don't really know where to look to find the answers. Once again, HCPCS code in the outpatient setting of care, if you're using a device, you're going to need some way of line item reporting that for reimbursement. There are obviously pass-through codes in Medicare, C codes, we call those HCPCS codes if there is one. Many private payers have sort of hijacked those codes that were originally pass-through codes for Medicare, and they utilize those on their fee schedules for reimbursement. And a common device representation code that we find in several payers is L8699. As you can see, it's really not even descriptive of a disc replacement, but that's what they want. That's something that policies and contracted guidelines, if you review, you can often establish the right pathway for line item reporting for your devices. And then revenue codes. Most people are familiar with the revenue codes. Once again, they're kind of an internal thing, but you want to make sure that you have all the pieces and parts and are communicating back and forth so you know what's going on in the facility when the surgeon comes in to do his procedure. Next slide. Coordination and communication is what we've been talking about. Once again, as claim processing programs become better and better, the connections between all these different codes and all the different reporting systems is going to be tighter and tighter. If they don't match up, claims get denied. And we've seen a trend, I'm sure many of you have recognized this, that used to be you'd get a line item denied, okay, but 4 of the codes got paid or 1 didn't. Now entire claims are being denied and have to go into the claim appeal process, which is pretty long and involved and never fun. Medicare is requiring surgeon documentation to support medical necessity, and they're requiring this when they're reviewing facility claims. Trickles down, and that's a very important aspect of communication coordination. They really do depend on each other now, because in Medicare's sense, and often with private payers, if one is found to be inappropriate, medical necessity not supported, both payments on either side of the equation are taken back. Managing your prior authorizations together once again, the surgeon's office, the scheduler, the facility know that process, know how to get over that hump so that you're not surprised at the last minute, 10 minutes or half an hour before the surgery starts, oops, the facility got denied on their prior authorization. Coordinate ahead of time. It saves a lot of time. Next slide, please. Identified as the third, in my mind, reimbursement component where we have problems or concerns is documentation. We've all heard the phrase, not documented, not done, more relevant than ever. Some old sayings go out the window. I think this one gets more appropriate by the minute. Procedure and device descriptions need to be precise in any kind of documentation. Just, oh, and I slipped in a disc isn't enough anymore. That won't fly with many payers. Watch for policy changes. These can happen frequently and without obvious notice. And all of a sudden, your medical necessity is no longer established because the policy of the payer changed, and instead of 6 weeks conservative therapy, you might have to have 6 months conservative therapy. If it's not reviewed, it may go through. No one knows. If it's reviewed, the payment comes back. It's a bump in the road with reimbursement. Payer guidelines are more and more specific now with indications as well. So once again, it ties back to coding and the language of coding, getting the indication to match up specifically with a diagnosis so that that's represented on the claim. Clinical history that supports medical necessity is now required, even for a prior authorization at times. If you go into an appeal of a prior authorization denial, you'll need that. Coding documentation audits are commonplace. Medicare has RAC audits, OIG audits, a host of others going on. And private players are now putting these into their contracts where they can come audit, do what they want, and have their own reasons for taking money back. Once again, ICD-10 codes, that scary word, they require even more specific documentation to support what's going on and medical necessity. Next slide, please. So how can documentation impact reimbursement? Multiple ways. You need documentation for non-surgical treatment. Ortho and spine procedures are being targeted by Medicare OIG plan. They say that right out. They give it to you the first of the year, what's going to be targeted, and those are targeted. Facilities right through to physicians. Denials in Medicare are based on medical necessity, and facilities are being held responsible for surgeon documentation. At the recent NAS coding update in New Orleans that I attended, it was pointed out that lumbar fusion procedures are attracting attention from CMS, and the focus is on medical necessity. The next round of the program for evaluating payment patterns electronic report, which is called Becker, will flag short-term acute care hospitals that are performing more than their fair share of spinal fusions. It's a little different than other targets because this time they're not just looking for the hospital admittance appropriateness, should they have been an inpatient, should they have been an outpatient, but they're also looking for medical necessity support, and this requires physician documentation. NAS suggested that hospitals may wish to proactively, and these are their words, proactively obtain previous diagnostic and therapeutic records from the surgeon and other pertinent practitioners. Once again, the need for documentation and communication between the surgeons and facilities. Now that's being flagged right out there by CMS and the Becker program. Should the lumbar procedure be considered not medically necessary by CMS? That's their determination. Both the facility and the surgeon payments are taken back. So communication, documentation. Why ortho and spine procedures? Why are they being targeted? Many reasons. They are often elective. and they need proof of medical necessity. The diagnosis coding has been not clearly defined. Hopefully in ICD-10 it will be more clearly defined, but we have to make sure we capture that. More emphasis on evidence-based medicine, aging population. Payer policies are vague about how they cover these. So your private payers are looking at spine and ortho procedures as it's a big area, and they're looking at it and changing their policies when they feel that they can. And also a lot of new technologies. A lot of new technology is in the ortho and spine area, and that represents reimbursement challenges of its own. Next slide, please. A fourth area of concern is knowing your contracted payer guidelines. And by that we mean, what have you agreed with your private payers that you will be able to do, and what you'll be paid, and how this affects either the surgeon practice or the facility. Knowing the revenue process for your payers. Often we have one level of maybe the CFO or someone looking into this, but it doesn't really trickle down to the coder sitting in the office trying to make sure that things are coded correctly and that things are appropriately approved for the surgeries that are necessary in ortho and spine. Knowing the revenue process, basically, it's your contract, your encounter, then you bill it, code it, then you receive payment, and then appeals if you're not paid. So the process should be shared with everyone in terms of where there can be reimbursement bumps. Specific payer charts, I would suggest that you make in your practice, not so much on the facility side, although it's important there as well, just charts that show, here's my top 5 payers, and here's what's required for this code. I have an example down here. It's just a simple example, and don't hold me to any of it. As you know, policies change, and they differ by contract. But your typical procedures that you use all the time, and what do your top 5, top 10 payers require for that, so that you don't miss a step, and the end of the line, get to the facility and they don't get a pre-auth because you didn't do something appropriately, or the whole equation doesn't work out because you neglected to do the correct imaging that needed to support medical necessity. Next slide, please.
Carolyn, if I may interrupt here for a minute, you had asked the attendees to participate in a poll before we continue on. Would you like me to, well, it looks like we launched that poll. So it will give the attendees about 30 seconds to answer the poll, and then we'll continue. Would that work for you?
Sounds good to me. Got a drink of water.
Okay, great. Okay, we'll give the poll about 15 more seconds before we close it, and then we'll share the results. Okay, let's close the poll.
Thank you, Kathy. We doing another one? Oh, there's the poll results. Great. Okay. Next slide, coverage considerations. Know your contracted payer guidelines. Obviously, contracted agreements between providers, contracted agreements with commercial payers between a surgeon and the payer, and also between the facility and the payer. Carve-outs are a real issue in terms of outpatient spine and ortho reimbursement. Want to consider during your contracting agreement times that you need to present the device-intensive procedures and how those will be reimbursed, how the devices will be reimbursed. This is a big impact in the outpatient and ambulatory surgery center, and needs to come before you start not being reimbursed or have no coding or pathway for that reimbursement for particular devices. So important to remember to make the carve-outs there so that something that needs to be paid for is brought to the attention of those making the contracts. Remember that private payers often have different guidelines than Medicare. We use the coding systems that are created by Medicare. We begin to feel that those guidelines are the ones that everyone follows. Be specific in your contracts and the guidelines that are in there, and review them so that you know that they may have something really off from what you're used to, and you want to be aware of that. Remember too that it's different in different states. State regulations have a lot of impact on how the insurance company can contract with providers, and that it may even be different from one side of the street to the other. Each facility may have a different contract with the same provider. Different plans factor into it. There's a lot of differentiation that is kind of under the radar. You can get into it when you're doing your contracting and be very secure in that your ortho and your spine procedures, particularly those that are device intensive, are going to be reimbursed appropriately. Keep your eye on your policies. They change without notice a lot of times. And if someone has the time to really check on that every 3 months, of your top 5 or 10 commercial payers, it's important, particularly your procedures that you do regularly and that are reimbursement concerns. And next slide, please. Outpatient ambulatory surgery centers specifically need to review their joint and spine procedures. Once again, minimally invasive procedures are very popular. The words are popular. What it means is not clearly defined, but you want to make sure that your contracted guidelines allow for those type of procedures to be performed in the outpatient setting and the ambulatory surgery setting. Different states have different rules for ambulatory surgery centers, so if I'm talking to people across the nation right now, some of these things, it may apply to you, it may not. It depends whether it's spine and joint procedures and to what degree those are being allowed. Private payers may be allowing more than Medicare, or they may not. And once again, HCPCS codes. Remember, what HCPCS code to report a device? A lot of times that's left out of the contracting. At the bottom, there's just a little chart that kind of shows what you need to consider as you consider your contracts and your guidelines that are being established for. Pick your top 5 joint and spine procedures let's say we're in an outpatient facility. Check what CPT codes, what the fee schedules are, how those are covered, and also HCPCS codes for your devices. And then know what is bundled. That's very important to negotiate as well. There's an example of this. There's some payers recently have just bundled knee procedures into one payment for whatever goes on in a particular session in an outpatient setting of care. I think that knowing that, negotiating that is very important. It could be that it's 2 very simple procedures and one fee is appropriate, but it also may be that things are being bundled that are really the work and the time and expertise required could be negotiated in terms of reimbursement. And then those all play into your coverage guidelines. And once again, make sure when you're contracting that something that you're talking about is actually a covered procedure, or you may want to negotiate that. And also technologies. How do they deal with new technologies? Are those covered procedures? Are they not? What do they require? And then that all leads to your payer contract. Next slide, please. And just for the final challenge, new technologies. And particularly, like I mentioned before, spine and orthopedic and joint, there's expanding technology every day. And we want to be able to, for the patient and for, healthcare in general, be able to access those new technologies when they're appropriate. Coding and coverage considerations, two of the big issues again, coding, coverage. Coding is not equal to coverage. You can have a code. It's created by the the AMA, has specific guidelines, it reports services, it has to match precisely. Codes can be controversial, and they also are determined by the physician. The ultimate authority is the physician. Coverage, it's not the same thing, obviously. That's determined by the payer. Maybe a great code, maybe a great procedure, and the payer is not covering it for one reason or another. They have local rules that apply. Sometimes diagnoses are tied very closely to their coverage. And new technologies are often not covered. So that's something that needs to be addressed if you're a new technology kind of provider. And proof of efficacy is the bottom line there for establishing coverage for new technologies. Even Medicare has locally decided coverage, local coverage decisions, and once again, we're talking nationally. So some of you are looking at one MAC and another MAC, and one side of the country you can do something and the other you can't. So knowing those policies, and particularly in regards to new technologies, is very important. Next slide. Sometimes we think that because the FDA has approved it, that then it's going to be covered. If you'll note on this slide, the FDA, they provide assurance that it's safe and effective, and the payers and CMS, Medicare, they're the ones that decide whether it's reasonable and necessary. So we have a two-sided equation again. FDA approval, of course, is necessary for payers to adopt a positive coverage decision, but just because it has an FDA approval does not mean there is a positive coverage decision. They're separate decisions, separate in each policy, and once again, for new technologies that have just recently gone through either the FDA approval process or the FDA clearance, it's important to look also to your coverage of those newly approved devices and technique. Next slide, please. What to do if you have a T code or an unlisted code? When you have a new technology, it's often assigned no code, which means you have to use an unlisted code, or if things have gone right, there may be a T code assigned to a new technology, both of which throw up red flags in the coding world and the pre-authorization on both sides, physician and facility. They are correctly reported sometimes with a T code. You have to use a T code when you do it. T codes they have their name because they have a T at the end, 4 digits and a T. They're actually temporary CPT codes, Category 3 codes that are created specifically for emerging technologies. And they're FDA approved, but they're not totally proven yet by the standards of CMS and Medicare to be covered. And then they assign them the T code. And the T code it's actually for tracking. They want them reported so they can see if the procedure is being done and ultimately plays into whether it's an established Category 1 CPT code or not. Medicare does not assign any RVUs. RVUs are used by Medicare to kind of rate procedures for reimbursement. RVUs are often used by private payers as well to establish their fee schedules, and T codes don't have them. However, sometimes Medicare will assign an APC to an outpatient setting of care for a T code. I've listed an example of 0275T, which is a percutaneous laminotomy, laminectomy, lumbar. It has an APC of 0208 established by Medicare, although the physician side of that equation has no RVUs and would have to go through a process, which is possible, to try and be reimbursed for that procedure. Unlisted codes are similar. If your procedure does not have a code, whether it's new technology or not, but oftentimes it is a new technology, then an unlisted code is used. Or if it's a combination of procedures, and then there's a process there too that, although time-consuming, it's possible to be reimbursed both on the facility and the physician side if time is spent to work through these are the unlisted and the T codes. And prior authorization is essential when you're using either of those codes, an unlisted or a T code, and also physician commitment, because it generally takes time. It's not decide today, do the procedure tomorrow type of thing, and generally takes an appeal process to get through and accurately be reimbursed for what's going on. Do we have a poll coming up?
Yes, we do have a poll coming up, and Lauren, if you can go ahead and launch that poll, and it will wait about 30 seconds or so and get the results coming in, and then we could move along. There are a lot of results coming in, so we're going to give it about 15 or 20 seconds more and see what the results are. Okay, Lauren, I'd go ahead and close that poll and we could share the results. There we go.
Okay, thank you, Kathy. Continue on to the next slide, new technologies and procedures, reimbursement reinvented. Can we go? There you go. Okay, now we've talked about T codes and unlisted codes. What are the strategies for using them? This is something that we do a great deal of here in the Reimbursement Management Center, and I've kind of gotten into the nitty-gritty details. 5 suggestions here that work. Common procedures reported as T codes. Make sure they're included in your payer contracts. You need surgeon commitment. And you need to have the surgeon and the facility involved, because it will affect reimbursement on both sides of the equation. If both are not reimbursed in the end, if it's a new technology or an old technology, ultimately it won't continue. The procedure, the facility can't get paid, but the surgeon can, or vice versa. It ends in the procedure not being there and limiting what can be done for your patient. Know the code description inside out. When you're using T codes, read the codes. They are much longer in length, I find, and more involved than permanent CPT codes. I don't know if that's a factor, if they're just being made today when we're more verbal and more expressive, or if they're just done because of the bundling. Many T codes, Category 3 temporary codes, are highly bundled. Watch for that. They often include imaging and bilateral, multi-levels in spine, and make sure that it matches correctly what you're doing. There's some very subtle differences in language there. One would expect the language to be more precise, but sometimes it's very hard to interpret the difference between something and what is mini-open, what is percutaneous, what is needle-based. There's some wording there that needs to be looked at very, very closely so that you get the right code and that you report it correctly. When reporting a T code or an unlisted code, you need a special report. And the special report is what generally gets things hung up. It needs to include technical information. You can, if it's a new procedure or a new device, if it's a T code or even an unlisted, get that information about the device. FDA approval. That's something that's not difficult to get. If the documentation of the FDA approval is difficult. Once it is approved or cleared, that information needs to be passed on to the payer. And the reason for medical necessity is that a surgeon narrative is very important as to why a patient would need a procedure that falls into an unlisted or a T code, as opposed to maybe the gold standard procedure that already has a permanent CPT code. Then also the fourth thing that's really important is to establish, and the surgeon is really the one that can do this, a crosswalk code. So there's a procedure that he typically performs that he feels takes the same expertise as the T code or unlisted code, same amount of time, the same amount of work. It can even be a different anatomy if the physician feels that that best represents the amount of work that he's done. And then map that to the fee schedule for that established CPT code. You don't report the CPT code that is the crosswalk. You just use that to justify in your letter that accompanies the special report. And here is the amount of time and effort and expertise that I believe this procedure that I'm requesting reimbursement for represents. And you need to always take it through the prior authorization and appeal process. Very rarely does an unlisted code or a T code just go through, although there are exceptions to that, and you will know that if something is a T code is typically paid by a particular payer, then there's no need to go any further. It may be on your fee schedule. And next slide. So in summary, the 5 biggest reimbursement challenges for ortho, joint, and spine. I would say be proactive. Procedures can and should be paid correctly by carriers for the best patient outcome. Avoid denials and take back from audits. A lot of joint and spine procedures are complex, and so are their coverage guidelines. Make sure that all procedures have complete clinical language and documentation to translate to coding pathways and communicate to payers. Cooperate within your practice and your facility. We spent a lot of time on that working together part. Over time, procedures that do not get paid on either side of the equation will be eliminated, and patients may not get what they need. So the communication and cooperation, time spent up front will facilitate correct reimbursement and avoid time and effort, which is not always possible in busy offices for claim denial appeal. Be involved in your contracted agreements. Put joint and spine procedures at the top of the list to be reviewed. Make sure that facilities are doing the same so that it's a win-win on all sides and things are not left out. And then, next of all, innovate for new technology. Prior authorization and prior authorization appeals allow surgeons and facilities to know in advance if their procedures that they consider new technology or maybe have to use a T code or an unlisted code are medically necessary and if they're likely to be reimbursed correctly. There's strategies that work for this. It works for reporting new tech. It takes a little extra time and knowledge and how to go through it. And then there's the 6th challenge, which I didn't put on here. I would add ICD-10 is around the corner. And the concern is not just can we implement the system, the new systems. We're all concerned about implementing it, but can we use the codes correctly? And therein lies the reimbursement conundrum. If they're not used correctly, it may be a negative to reimbursement. If it's a positive, if they're used appropriately and with great specificity to report what is actually happening, it'll be a positive for reimbursement. Emphasis needs to be placed on the accuracy, accuracy, accuracy. Number one concern, one digit off and the whole thing goes down the drain. I'd like to thank you all again for your time and your interest, and enjoy the day. Kathy?
Thank you, Carolyn, for an extremely informative presentation. We're now we have a few minutes left for the Q&A portion of the program, and as a reminder, you can enter your questions into your control panel in the space labeled Enter a Question for Staff and clicking Send. And we'll attempt to answer as many as we can during the time we have. But I want to draw your attention to the last slide you see here on the screen, and feel free to contact Todd Schuck, who is the Senior Director of Business Development or Specialty Healthcare Advisors. And Todd can be reached by email at tschuk@sha-mcra.com, or you can call him at 860-770-6742, and he'll be able to address any of those questions we don't have the time for today. Carolyn, we do have a first question here. You mentioned that you provide coverage access services, pre-approval, prior authorization, and denial management services. Can you elaborate on how you deliver those services?
Sure. We can deliver those services either independently to providers or as a component of our Reimbursement Management Center hotline subscription. We work with both surgeons and facilities to provide simple coding assistance, or all the way through to working specific cases through prior authorization, verification of benefits, submission of prior auths to the payer and facility, and the appeal process if necessary. Generally, the client chooses the level of assistance for their unique needs, and we work out a program that works for them.
Okay, thank you. Does your company perform surgical chart audits? And if so, can you speak to what you perceive to be the benefits and drawbacks of having an outside company perform this type of audit?
Sure. I think the biggest benefit is just a new pair of eyes. We all get used to what goes on. It's like proofreading your own work. It's very hard to see the simple errors. You certainly see the big errors right away, and you would work with them. And the other advantage is that we have very specific knowledge of current documentation and coding guidelines in the ortho and spine landscape. We've worked with this, the whole team works with this on a daily basis into the nitty-gritty, way beyond the simple let's put a code on it. So we all make common mistakes over and over again, and having my colleagues look at my work and having another colleague in your court brings us all to a higher level of accuracy. I think that's where the biggest benefit is, that you get past the kind of the blindness that we have for our own errors.
Okay, thank you. What are some of the more common spine and joint replacement questions that come through on your coding hotline service?
Well, in joint replacements, I would say the most of the questions revolve around what can be coded together and what cannot be coded together. And specifically, what's documented in the op note and how that relates to, like I say, the language of coding. There's sometimes, even billing services or someone that's not very closely working with a surgeon all the time will want to know how to interpret a particular part of the language, or the surgeon isn't very clear about what codes he's established, and we can sometimes assist with that. For spine procedures, we get questions regarding multiple level procedures and most oftenly new technologies. Coverage questions arise when we assist with prior authorizations, and this includes indication and conservative care requirements, which are often buried deep into private payer policies, and that's another area that we get a lot of questions about.
Okay, perfect. This question is, where does neurophysiologic intraoperative monitoring fit into the future reimbursement strategies?
Well, that's a really good question, because there's been some very recent changes in the CPT coding process as to whether it can be done multiply off-site, whether it needs to be done inside. I would say from the viewpoint of the changes that have gone on recently within CPT and also Medicare coverage, where they've even established their own code and not adopted what the AMA CPT did. It's under review, and I would say that it would need a close eye. And also, that's Medicare. Private payers oftentimes don't reflect that, and the policies right now, from my experience, are across the board. Some have changed to time-based, or more specifically, the CPT AMA recommended time-based policy. Some have not. I would say to have a specific answer to that would be kind of looking into the crystal ball, but I think it's a good question and something that needs to be reviewed every year to see what the changes are and to watch the payer policies.
Thank you, Carolyn. We have time for one more question, and that question is, where can I find more information on the Medicare Pepper program referenced at the NASS course?
Well, actually, my first reference always is to just Google it, and P-E-P-P-E-R, and you will see that it comes up under with the Office of Inspector General and CMS. You can find out information there on the CMS website if you like to go there. It's a little difficult, but some of the fields actually have some search and find now, and you can find information. It stands for, I don't know if I can even say all the words appropriately. The acronym is Program for Evaluating Payment Patterns Electronic Report. So Pepper. And that, what it is another outreach of the CMS and the Office of Inspector General into reviewing their data that they collect, and then going out telling people what they're going to be looking at. They actually tell facilities what's on their list, and then when they do an audit, they try and find either errors or things that don't conform to their standards and their guidelines. If you want to send me an email, I could send you a link for that too. Whoever asked that question.
Okay, well, thank you very much. I want to again thank Carolyn Newman for her excellent presentation today and for all of you who participated today. We look forward to having you join us again for future webinars, and this will conclude today's program, and have a wonderful afternoon.
Thank you very much.